Welcome, everyone. Today, we'll be going over the art of the ask, querying for clinical and financial accuracy. My name's Barbara Phillips. I'm a senior consultant for Anderson Health Information Systems for a number of years. Today, the webinar is going to be for a general educational offering. It's not intended to be legal advice or professional advice in any specific situation. And to the best of our knowledge, it reflects current state and federal regulations and practices, and they do not represent any specific employer preferred electronic health system or information technology. A little bit of housekeeping. Participants that would like to receive one BRN credit for their attendance today must be present for at least 80% of the presentation in order to receive the CE certificate. And if you'd like that certificate, you'll need to contact AHIS at the information on your screen, Lisa at AHIS, or the phone number above, and they will send you your BRN certificate. So what are we going to do today? We're talking about mastering the skill of crafting effective compliant queries, and we're wanting to enhance documentation integrity, of course, drive optimal reimbursement. So our objectives today are we're going to define the importance of queries. What are they? And common documentation gaps related to queries and why you might need to do a query to support your coding and your reimbursement. Also, some best practices for crafting queries and that align with AHIMA and ACDIS guidelines, who are the industry experts on queries. And then also we'll talk about collaborating effectively with the ID team, which is also a part of getting effective documentation to support your reimbursement. Well, queries are not just a compliance requirement. They're a tool to ensure that you have accurate clinical documentation and you receive the outcome that you want to support financially. We're going to explore the art behind querying today and how we can effectively communicate with physicians and go beyond compliance. We're capturing clinical complexity. We're going to support accurate coding and, of course, optimizing our reimbursement. So whether you're refining your current process or building a stronger query culture, this session will equip you with some practical insights to improve your both compliance and reimbursement. So first, we'll start off with a simple, what is a query? It's a communication tool used to clarify documentation in the health record to support an accurate diagnosis for a specific encounter. And it also may be initiated by healthcare professionals or generated by automated systems. In long-term care, we are not usually using automated systems. That's more related to acute care. You may be in systems like Cerner or Epic, and they have query systems built in. In long-term care, we're still more in the manual stage unless your facility has purchased a query system. But most of those are going to be relying, most of us, on a more of a manual process. And today we're going to show you how some of those processes work and how to draft compliant queries. So common terms for queries when you might need one would be when you need clarification, clinical clarification, documentation clarification. There's things like prompting, nudges, or alerts. Those are more in a system where it's telling you if you have an incomplete code, you'll get a prompt or some sort of an alert that what you have entered is incomplete, and you may need to get additional information from the physician to assist you in getting a more compliant code. Regardless of the term that they use, if it meets the purpose of clarifying for coding accuracy, it's considered a query. So documentation drives coding. So we need the correct diagnosis to support our reimbursement. So the gaps are common, and often it's like missing, vague, or conflicting information that can't be used as is. And we run into that a lot when we're looking at documentation that's in either the acute care documentation or it could be the skilled nursing facilities history and physical or progress notes, what the physician writes may not give us enough to really get the full picture of the complexity of that patient. So physician queries can fill those gaps and reflect that true clinical picture. And it will also support your compliance and accuracy. So they align with the ICD-10 coding standards and the regulatory requirements. So we'll get into that a little bit more in the future of this presentation, but we're going to be looking at aligning with the current standards of practice for querying that are supported by the ICD-10 official coding guidelines from CMS. And the definitions that we're using are all directly from either CMS or they're from American Health Information Management Association, or ACDIS, the experts in the field. So lack of specificity in diagnosis is very common. You've all seen these terms like infection or fracture when they're not specifying the type, site, or cause. We may need to query. Another common issue is unresolved diagnosis. Conditions mentioned in the history and physical or problem list, but not addressed in the current encounter. So they addressed it in the acute care, but not necessarily in the skilled nursing history and physical when they come in. So we're not sure if it's being actively treated. Or where there's no clarification whether a condition is active, resolved, or ruled out. We'll see conflicts there occasionally where in the acute care record, something may say resolved, but when we get the skilled nursing documentation from the physician in his history and physical or hers, it will sometimes become an active diagnosis. So those clarifications will need to frequently query the physician to get the definitive diagnosis for coding or whether or not to code. Another area is inadequate documentation for MDS diagnosis. So diagnoses that impact the MDS, like depression, delirium, swallowing disorders, may not clearly be documented or supported by the MD documentation. In those cases, we'd want to query. Also, improper use of history or status terms. So misuse like history of stroke when the patient actually has active sequela related to that stroke that you could use an I-69 code and apply that, and it would actually affect, in many cases, your PDPM scores. So you're going to want to query in those cases. Another thing is excludes and includes docs. So if you're using the coding book, and I hope all of you that are coding are using the official coding books and not just Googling for codes, because you really have these includes and excludes conventions that you need to take into consideration. So sometimes, for example, if you've got something that is congenital, whether an acquired form of the same disease, and we don't have it clarified by the physician, you would need to clarify, was this congenital condition or was it a acquired condition? The other thing is missing clinical indicators, diagnosis listed without supporting signs, symptoms, test results, lack of documentation to support medical necessity or acuity level. So again, you're going to want to see the complexity of the condition and get the fullest picture that you can to document in the record to support what you've coded in the MDS and what you have got on your diagnosis list. So a compliant query includes a non-leading query statement. So in other words, please clarify the diagnosis. Can a diagnosis be provided? So those are kind of statements where we're asking for clarification or for a diagnosis, but we're not leading the physician. And we'll get into that in detail. Clear, concise, specific necessity of the query supported by clinical indicators. So the titles of the query should be non-leading in nature. And this is straight from ACDIS. We have queries, but and we'll show you some in the presentation as we go along, that we don't have any of the titles on the top of the query. It has the clinical indicators. It has where you can outline the condition of the resident and ask the question to the physician of whether or not we can get a clarification or provide a diagnosis. But we're leaving everything up to the physician to make that determination of what that diagnosis may be. So we're not going to put that title up there saying malnutrition and then down below it's kind of seen as possibly leading. So we're getting away from that. That's the most current view from AHIMA, and we're following that lead. And in our query packages, normally what we have is the name of the query is in the document title in your when you're just saving your document, but it's not printed on the form. So again, you should never include things like reimbursement, impact, quality indicators, other specific diagnosis, or new information that's not already included in the health record to get a desired response. That's looked at as leading. So we're trying to make sure that we don't look like our queries are leading. And we have had questions from surveyors in the past. Rhonda Anderson actually did a webinar with a group of physicians where the surveyors had specifically asked, what is your query process? And I don't remember if it was a malnutrition, but one of the more common ones where we're frequently querying physicians. And they wanted to make sure that the physicians were aware of the process. And so it's not something that it's just going to be looked at by from a reimbursement standpoint. You know, if you get a MDS review or an MDS, a Medicare review, pardon me, it can actually be looked at even by a surveyor. In this case, it was. So if you identify information coming from the chart, you need to specify what the source of that information is. So when you're doing those clinical indicators, you want to identify where did this information come from. Here's some options. So we're going to talk about different ways you can query. A multiple choice query only includes the relevant options supported by clinical indicators documented in the record. So we're not just positing what we think might be the case. We are using objective information that we've pulled from the medical record. It includes the answer option of other or similar terminology to allow the provider to customize the response. So it never needs to have any opt-out for the physician. You've always got to, excuse me, got a hoarse voice this morning, guys, sorry. You always want to give the physician the maximum latitude to provide their diagnosis in the way they'd like to provide it. Answer options that might be used but are not required include things like unknown, not clinically significant, integral to, unable to rule out, inherent to, other similar wording. And there's no minimum or maximum amount of words that you can have in a query. So you have a lot of latitude on the way that you draft these queries and the way that they look, including in a multiple choice. Unable to determine choosing as a multiple choice option does not mean unable to rule out. It represents an uncertain diagnosis like possible, probable, or unlikely. And we all know we cannot code those. You cannot code possible, probable, or unlikely as a diagnosis. If that's the case, and that's what your query determines, you have a code, you cannot code it. You're going to present only documentation pulled from the record without subjective interpretation by the person querying. And again, never include impact on reimbursement, quality measures, etc. The diagnosis answer options must be supported by clinical indicators sourced from the medical record. So in other words, we're giving clinical indicators, and we'll go through examples of this, about what the condition of the resident is, and they need to be clear and concise, directly support the condition requiring the clarification, and then allow that provider to clinically determine the most appropriate medical condition. So we want to paint a clinical picture of the diagnosis query to be added or validated. So you're setting up the scenario based on the clearest possible picture of this resident's condition, and then allowing that physician to make that determination. Diagnosis answer options must be supported by clinical indicators sourced from the record. So in other words, they've got to be either they have to be specific or directly related to, but not necessarily from that specific clinical encounter, and support documentation that translate to the most accurate code. So what am I talking about here? You can get clinical indicators from all kinds of places: ED records, hospital progress notes, consultant notes. It can be from imaging findings. We can't code from a lab or an x-ray. However, we can provide that to the physician as a clinical indicator of the resident's condition. And that would be setting up, okay, here's the resident's condition. These are what the lab results said, or this is what the imaging or x-ray findings said, and allow the physician to come to a determination of a diagnosis from that standpoint. It can come from relevant prior visits that are also clinically applicable to the present encounter. And it can also come from ancillary professionals like nursing, nutritionists, wound care, PT/OT speech therapists, respiratory therapists. You would quote where that information came from, setting up your clinical indicators and providing the picture to the physician and asking for them to come to a determination of an appropriate diagnosis. And one of the answers might be not clinically relevant. So if you need help setting up query systems, AIS can help you with that, either remotely, even if you're not our client currently. We can assist you remotely or on site to set up a query system, but we provide additional services, including Medicare reviews, PDPM and coding and compliance reviews, quality insurance, performance improvement initiatives, and survey preparation. Again, this can be done remotely or on site. But if you'd like more information about that, you can contact us at ahis.net. If you wish to provide a query set, and we'll be looking at some of our queries today, you can also contact us on the website or by phone. We'll give information at the end of the program of where you can go to purchase a query set if that's something that interests you today. So non-compliant queries, here's where we really get into the details. What are leading queries? So it suggests a diagnosis or condition to the provider, and it's non-compliant because it can influence the provider's response. So that's what you want to make sure you're not doing. They compromise the integrity of the documentation, and it can lead to inaccurate coding and reimbursement. So let's give some examples of leading queries and compliant versus non-compliant. So the first one is the patient's pneumonia due to aspiration? The compliant query could be stated as, can you clarify the cause of the patient's pneumonia? Can you see the difference? We have not added that word aspiration, leading the physician to say, hey, can you give us a diagnosis for aspiration pneumonia? We have let the doctor decide what is the cause of this pneumonia. Is it aspiration pneumonia, etc.? Another example is for COPD. Is the patient shortness of breath due to COPD exacerbation? So we've already given them the diagnosis we want there. We want to dial that back. And the compliant query could just say, please clarify the cause of the patient's shortness of breath. Again, up to the provider to make that determination. And a third example is the patient's anemia due to chronic kidney disease. The compliant query would be stated as, can you clarify the cause of the patient's anemia? So I think you can see the difference there. And this is a trick to doing this. I mean, even when I'm doing it myself, I have to think about how this needs to be worded to not appear to be leading. So you want to, here's some best practices. You want to be clear and concise. You need to be neutral and not identify diagnosis that's not already documented. So, and I'll give you some examples of that in a little bit later, but one would be like if we've got a diagnosis already and we're looking for the respiratory failure, for example, we can indicate that we have a diagnosis of respiratory failure, chronic or acute respiratory failure, but we could ask for a clarification from the physician whether or not this is a current diagnosis. And then the physician could go on to determine, oh yeah, this is acute on chronic, this is chronic, this is acute. So those are the kind of conditions where if you already have a diagnosis and you're just looking for a clarification, you can include that diagnostic wording in your query. So clinical relevance, of course, the clinical indicators need to be based on the documentation in the record, and you have to have a good formatting structure that identifies the resident. It introduces the problem, the indicators, gives query options, and information should be customizable for the physician or editable. So it can't just be something where the physician, doesn't have options. And we'll get into some scenarios for yes, no queries, which are occasionally an option. But again, you need to give enough options for it to be only the physician that's making that determination without being led. An open-ended query allows a provider to add free text query responses based on their judgment, and it may or may not align with documentation needed to support the code assignment. So one of the issues there, if it's free text and you don't have a multiple choice system, you may still not get the diagnosis you're looking for if the doctor's just giving an answer. So sometimes if you have a multiple choice format where there's additional diagnosis that can be chosen from, including not applicable, or not clinically relevant, then it kind of cues the physician to, okay, here's some options for this diagnosis, and they can make their choice based on their clinical judgment. So a multiple choice format includes clinically significant options, providing a new diagnosis in a multiple choice list supported and sustained by reference from clinical indicators is not introducing new information. So let's take a look at one right now. And as you'll see here, there's no title up there. It's just kind of blank. But here's where you're going to put in, the resident's name information. And then here's the issue. Based on the information documented in the record and address, the following information is documented in the record. You could put whatever that picture is that you're painting and indicate what the clinical indicators. You could have labs, you could have x-ray results, you could have vital signs, whatever it's going to support your case. And so in this particular case, we're also giving the choices. So this is an anemia query, and we're listing some options for possible types of anemia, including, though, other and specify, clinically undetermined. So again, you could not code it that, or not clinically significant. So we've given all of these options, but it's up to the physician to determine what type of anemia this is, or if it's even clinically relevant. Now, one of the things I want to point out here is that we have a statement above here. This bottom part can only be completed by the physician. The clinicians in the facility can fill out, or the coding specialist, MDS, can fill out the issues and the clinical indicators, but only the physician can document the actual diagnosis. In setting that up, though, we want to clarify in this statement here, in responding to this request, please exercise your professional judgment. The fact that a question is asked does not imply that any particular diagnosis is desired or expected. So we're pretty much saying, this is up to you, physician, and it's your clinical judgment. So again, it's just kind of a way of being very, very clear that we're not asking for anything specific from them other than to make a determination. Querying format options. Okay, yes, no queries. They can only use to clarify a documented diagnosis that needs no further specification. So very limited use on yes, nos. It may not be used where only clinical indicators of a condition are present. So you can't just, give the clinical indicators and say, is this pernicious anemia? That would be better off if you gave them that anemia query and it has multiple options and the physician can choose whatever option is the most clinically relevant to them. And you can't use them also where the condition diagnosis has not been documented in the health record. So you can't just introduce a diagnosis, say, doctor, is malnutrition a diagnosis? Yes or no? That is not a proper query. So yes, no query should include only documentation in question, relevant clinical indicators. That could only be answered with a yes or no. So sustaining a diagnosis that's already present in the current record, like findings in pathology, radiology, diagnostic, with interpretation by provider in an inpatient setting. So if you've got something that you've got a lab result, you've got a an X-ray where we've got a specific type fracture, for example, you can give that as one of the clinical indicators about the specific type of fracture, and the physician could answer yes or no. So that would be an appropriate use of a yes or no query. Also for resolving conflicting documentation from multiple providers. And you'll see that where you have, one physician says it one way and one physician says it another way. And maybe the physician in the facility has made their statement and you're going to say, dear doctor, we have this documentation in the record. The documentation of the diagnosis you give us is this, this particular diagnosis, acute on chronic respiratory failure. Is this the current active diagnosis? You could get that as a yes or no. Why? Because we already have the documentation in the record. We're just asking for clarification. So you're going to solicit the physician review and approval of your queries if you're just setting up a system. And you're going to submit those to QAA or Resident Care Policy Committee for final approval. So you really want the buy-in from your physicians on this particular process. The query policy. Now you should have a physician query policy and about how you maintain the policies and retain them in the record. It's usually per the record retention policy. And this is not so relevant unless you have a lot of doctors in your facility, the escalation policy for unanswered questions. Most of the time, if you've got a practice where you've got, a number of doctors coming in, for example, sometimes we have physicians that are rotating in from big practices at Kaiser or one of those type of situations where you've got different doctors coming in and giving diagnosis. You might need to escalate that up to someone else to make a determination about that diagnosis. That's not so popular, or not so popular, but not so relevant in our level of care. It's more in the acute care where they have lots and lots of doctors and, they need to get the top dog to determine what that is. Or sometimes the doctors aren't answering the queries is when you'd have to escalate up to get an answer to the query. So it's never meant to intimidate or direct a response from a provider. We're not escalating up because we didn't like your answer. If you get an answer from a query, that's usually the answer. You're not escalating it up because you want a different answer. Now, there are certain kinds of tools that we can use for monitoring and trending to monitor the rates and timeliness. So this really depends on how much querying you're doing in your facility. And you can look at provider responses and trends. You can use data to identify educational opportunities. You can utilize sometimes the HIM consultant coding accuracy reviews to detect missed opportunities due to insufficient documentation of diagnosis where a query was needed. Also, we want to communicate with the business office to track denials for insufficient documentation of diagnosis. And we just have a very simple query tool that we have here that you could actually, query, start tracking if you're doing queries, what type it was, the reason for it, the response status. On the business end of things, you could look at, was the claim denied? What was the reason? The denial amount and appeal. So this is something I don't see as much out in the facilities, and I don't see a lot of communication between the coders and the business office in many cases. But it's something you'd want to look at in your facility. Are you having denials? Are any of them related to, coding? And whether or not a diagnosis was supported. You're going to want to utilize those trends to improve your documentation practices. So if you do have denials, if you are not getting your queries back, you're going to want to look at what are the conditions around that and try to, you can copy some of it if it's a big issue and report your findings to QAA. The results and trends to identify any corrections needed. So you're really going to want to look at everything. And then if you do end up correcting, so a lot of times when we're doing PDPM reviews, for example, we'll be looking at situations where had a Sequela code been clarified and coded as an I-69 code, we could have possibly received additional reimbursement for that particular diagnosis. Or conversely, we had say a therapy diagnosis and it was the principal diagnosis, it was not directly documented by the physician. It was only from therapy. And we might need an MD clarification on that. If we end up doing a modification, like in many cases when you're doing a PDPM, if you don't find the supporting documentation, you're going to want to do a modification to and pay back the money. You're going to self-report and change your MDS. Or, I mean, conversely, you can also go the other way and indicate that we did have additional documentation to support a diagnosis. And in any case, when you're doing these modifications, though, if something has changed on the billing, then you need a billing claim resubmission. So again, the MDS modifications are something that can be done when you're looking at your trends and whether or not you have the supporting documentation related to the appropriate diagnosis. So who do we query? Well, of course, you're going to query the provider actively involved in the resident care. This is most, pretty easy in skilled nursing. It's almost always just going to be the attending physician. Sometimes there are multiple providers that are involved, and it could be like in our case, it could be a psychiatrist or a wound doctor if you're looking to clarify specific things. Maybe you've got conflicting documentation or incomplete documentation. Then sometimes you would go to the provider related to that specific episode of care looking for that query. The other area is non-provider clinicians. And so this is for non-diagnostic information. So in other words, on wound care, in order to appropriately code the stage of the wound, you're not always going to get that from the physician. Now, if you have wound doctors, it's probably there. But we can go to the treatment nurse to get a clarification on staging of wounds. The dietitian for BMI clarification, or the respiratory therapist related to mechanical ventilation details. So sometimes it's appropriate to query non-provider clinicians. And in our ACE queries packet, we do have non-provider treatment nurse provider, a unspecified principal diagnosis query, where in these weird situations where you're looking, you may not have to have a doctor diagnosis on the non-provider clinician side, you want the non-provider clinicians to give you a clarification on the specifics of things like wound details. On the unspecified diagnosis, so that would become principal diagnosis, you would actually be going to the physician anytime you're related to a principal or a diagnosis. That's always going to come from the physician. And like I said, we do have a query for that in our query packet. And those are hard. Sometimes people come in from the acute, and we really are struggling to find a principal diagnosis for that resident. So when do you query to support clinically evident conditions that aren't explicitly stated, to resolve conflicting diagnosis, to confirm a diagnosis, and establish cause and effect? Sorry, I went too fast. So query as needed to establish the relevance, like if you've got a history of, to decide is this active or not, determine if it's ruled in or ruled out. We see that a lot where we've got, by the time they got discharged, they weren't clear on whether or not something was ruled in or out. Clarify the presence or absence of a complication. Clarify diagnosis on an ancillary note that's been signed but not addressed by the provider. So an example would be a nutrition note that states severe malnutrition, and the note is signed by the provider, but the provider does not address the diagnosis in their documentation. So again, if that doctor is, let's say they're agreeing with what the RD wrote, and maybe they even signed that, or they signed a list someplace, that's not the documentation you need. It needs to be in the physician's own progress notes or history and physical. You're not, avoid query fatigue. I don't think we're there yet in skilled nursing, but you don't want to over query. You really want to query when there's insufficient documentation to assign a valid code, and you're going to focus on those ones that are really related primarily to the main conditions that residents in the skilled nursing facility. And only query when the data supports the answer choices. So you're not just going to be fishing for diagnosis. You really need to have clinical indicators to relate to that episode of care and ask for that clarification. The timing of the queries is important, and we've seen that when we're doing our PDPM reviews, is that if the queries are not coming back on time, and some of you may have run into this, we cannot code a diagnosis on the MDS if that query was answered after the ARD, the Medicare 5-day. So that's really important if you're getting these late queries back. We might be underrepresenting or underreporting resident acuity. And CMS requires all documentation used for coding be present in the medical record by the ARD. Anything other than that is non-compliant. So again, they're used for, the diagnoses are used for accurate care planning and ID team coordination. So we want to make sure that we get those diagnoses spelled out and clarified and any queries answered by the assessment reference date. So here's some key risks that are related to queries. Of course, CMS requires complete, accurate, clinically validated documentation. So one of the things, and this is kind of the other side of the picture, not querying when needed may violate federal documentation standards. So you want to provide the clearest possible picture of that resident's acuity. And if you fail to query when something is, needed to be queried, it could be looked at as negligent. Or misrepresenting for overbilling or underreporting. So again, it goes both ways. You want to make sure that you are presenting that clear picture and query when you need to. And AHIMA actually has an ethical standard that emphasizes the duty to query when it's necessary. So also the incomplete or unclear documentation can, affect your star ratings, your value-based purchasing. Caveat, never mentioned the fact that might affect that in your query. We said that earlier on in the presentation, and I have actually seen that in queries before, where people are saying, "Dear doctor, this is affecting our, star rating or whatever. We need this documentation." Like the schizophrenia one is a perfect example of that, because you know that if you do not have the proper documentation for schizophrenia, that it can reduce your star rating. So even though that's the truth, you never want to include that as part of your query. CMS can classify your claims as improper if your documentation doesn't support your billing, and it can result in recoupments, audits, or penalties. And then also it can end up with inaccurate coding, and it undermines the accuracy of your PDPM case mix if you do not have clear diagnosis. Accurate queries support PDPM and reimbursement, and it impacts the PDPM case mix classification. So missing or delayed queries can result in lower reimbursement due to unrecognized conditions like depression, cognitive impairment, and comorbidities. And we saw a lot of that when doing PDPM reviews, that, we don't have the proper documentation in the record to support these diagnoses. And you can reduce denials by clarifying that documentation to reduce the risk of claim denial and support services provided and medical necessity. Another issue related to this entire process, not just the query, is the IDT collaboration. So we're going to bridge communication gaps and facilitate clear, compliant communication between MDS, HIM, therapists, providers to clarify ambiguous or incomplete documentation. So you could use something like a structured diagnosis worksheet, facility approved query tools, and educate your staff and providers on the query process. So this is just an example of, many of you have this, where whoever is assigning the codes is filling out a sheet like this and sequencing them, and then the coder goes along and assigns the appropriate code. But they have additional checklists where you can identify specific diagnoses that are affecting things related to, the clinical categories, NTA, NTA, SLP, etc. So some of these clinical tools are very helpful in making sure that we get the most specific diagnosis related to things like, I was looking for the one on SLP comorbidities. So, and therapies. So again, it's showing you the I-69 codes that could relate to this. And a lot of times you may need to have a physician query, especially sometimes on the sequela, to make sure that we're picking up those sequela in supporting documentation. So you may have tools available for your use to help you to pick up the diagnosis and figure out, do we need a query or not? So the queries support clinical documentation integrity. It helps the MDS coordinator obtain specificity for documenting the MDS accurately and completely, especially for PDPM. You can improve, your collaboration will improve the reimbursement accuracy. We're going to proactively address documentation gaps leading to denials or retrospective, corrections. Again, if you're communicating with your business office, and a lot of times, I know we're going through a lot of this stuff, in PPS meetings and in triple check, but if you're having any problems with incomplete, not having the specificity that you need in the diagnosis or getting any kind of denials, you're going to really want to back that up and analyze the causes for that and make sure that we're proactively addressing that and, eliminating those issues going forward whenever possible. So again, communication with that business office. You can have HIM consultant reviews for IDC coding accuracy and documentation to support your billing. And, of course, you're going to want to promote a very robust weekly PPS and monthly triple check. And I know those can go on forever. And you want to make it as succinct as possible. But, if you're looking at your trends, that's when you want to really drill down and say, okay, we have an issue here, and start looking at it more completely when you're doing your PPS and triple check. So we need some provider education to enhance the query effectiveness. So the query alone might really not fully inform the provider of what we're talking about, what we're expecting. And again, like I told you before, Rhonda ended up doing a training for the medical director and physicians in a facility at the behest of the surveyor asking, and because the physicians did not seem to be informed about what the query process actually was. You need regular training, so just make sure your providers understand and how to respond, especially if you've got a new process. If you're in establishing a new query process, you're going to want to introduce that to all of your providers. And in cases where, let's say, you're getting things back that are not correct or they're coming back late, you're going to want to use some de-identified case studies to say, okay, doctors, here's where we're having some issues, and give them some examples. And of course, you're going to want to train your staff. So here's an issue where a dietitian notes and dates sign of malnutrition. Provider has not provided diagnosis. The problem, malnutrition affects PDPM and quality measures and cannot be provided with or coded without provider confirmation. We all know this one. So here's an example of a compliant query. Okay, so you're going to want based on clinical indicators, unintentional weight loss, reduced oral intake, can you determine whether or not the resident meets clinical criteria for a nutrition-related diagnosis? Do you see the difference there? I did not put the word malnutrition anywhere in that statement. Since the diagnosis is not yet documented, you're going to use a format where malnutrition is not part of your header. So here's an example of, we've got no header up here. We're going to put those different statements in there, painting that clinical picture. We're going to indicate what those particular clinical indicators were for that patient, that client or resident, and then anything that applies. And then we're going to allow the physician to complete their portion of the form and give us what they feel is the appropriate diagnosis. Another example is flat fracture without trauma clarification. So we've got a femur fracture, it doesn't indicate whether there was trauma or not. and unclear whether it's traumatic or pathological, which affects coding and care planning. And that happens a lot, the fracture one. So again, can you clarify whether the femur fracture is traumatic or pathological in nature? In this case, the header of the query may include the fracture since the provider has already documented it. We've already got that it's a fracture. We just don't know the specifics. It only seeks clarification. So again, we don't have fracture in the form here, but we're going to spell it out here in the issues, and we can indicate that there is a fracture, but we're looking for clarification on the type of fracture. And below, the physician can indicate whether or not, it was pathological or whether it was due to injury. And sometimes usually laterality we can pretty much figure out on our own. But again, we're giving the options here for the physician to sign and date that particular query. An issue statement, undetermined principal diagnosis. Again, that's one that's can happen. Resident submitted for chest pain per the ER report. Myocardial infarction, day 2, MI ruled out per discharge summary with the date, chest pain is resolved, no other diagnosis given. And then we're going to say the therapy evaluation show that therapy treatment of muscle wasting and other lack of coordination. Physician, please provide a primary diagnosis for the treatment in the SNF based on documentation provided in the chart. So again, another one is issue non-traumatic head injury, the H&P resident admitted for right intracranial hemorrhage, no MD documented result of residual effects. Therapy evaluations show therapy treatment of dysphagia, left-sided hemiplegia, cognitive communication. Physician, please clarify if any residual effect or diagnosis apply for treatment in the SNF. This is the one where we're looking for that principal diagnosis. You can't just code from what therapy wrote. You've got to have that physician specify what those sequelae are. So post-physician completion of the query, we're going to forward it to the coder for coding. We're going to update the diagnosis list, notify therapy, update MDS in the computer if needed. We're going to reprint that base sheet if we have a paper chart. We're going to keep CDI MD query sheet as part of the chart for supporting documentation. Very important. You have to include your query in the chart if you're, providing a written query to the physician. And a copy of the query is included with any ADR request or request for record. So that just becomes part of your clinical record. The key takeaways from today: queries are essential for capturing clinical complexity, supporting your coding, and making sure that you're optimizing your reimbursement. Want to make sure that both our staff who are drafting the queries and the providers are educated on the query process. You're going to want to use a structured format to facilitate compliant querying. So you're going to need to sit down in your facility if you don't already have one and look at what you're using for your current querying practices and clarify that. Come up with a policy if you don't already have one, and make sure that everybody is on the same page. It's if you do adopt a new one, your querying process, you want to have it looked at by your providers, reviewed and approved at your patient care resident care policy committee or QAA. You want to maybe conduct a regular pre-billing reviews to make sure that we have our diagnosis, especially on those heavy PDPM related diagnoses. You're going to schedule HIM consultant coding documentation accuracy reviews. A lot of times when we're doing those, we'll pick up where if you had done a query, you could have had additional reimbursement, or we'll pick up that something was coded that we don't have the supporting documentation. So that's the value of some of those. And you're going to want to review your results and trends and identify and make any corrections as needed. So in conclusion, querying physicians is not just a best practice, it's a regulatory and ethical obligation. It promotes accurate coding, supports appropriate reimbursement, and protects the facility from compliance and financial risks. So I want to thank you all for attending today and taking time out of your busy schedules. I know that this is an important topic, and again, thank you so much for being here. If you have any questions, please feel free to reach out to us. You have the contact information on the screen. And again, if you wish to purchase a set of queries or inquire about them, the information is available on our website at ahis.net, or you can call or email the office for that information. Here's the list of resources that were used in providing you this in-service today, or this webinar. And again, thank you so much for attending.